This is the last session before noon. And I'm privileged to introduce Deborah Kado from Stanford. And she's now doing quite a bit of her work at the Palo Alto VA. So we shared VA stories. So she's going to speak to us on osteoporosis treatment in the very old. And I'm interested to know what the definition of the very old is. Deborah?
Thank you so much. And thank you, Dr. Lewicki, for inviting me to Santa Fe in this phone symposium. So I do have some disclosures. The one that I'm going to talk about is the VA federal employee part, where the views that I'm expressing in this talk are those of me and not necessarily the government or the Department of Veterans Affairs.
Well done.
Okay, so I was asked to give this talk and I was given the title. So just like you were probably thinking, very old, what is that? So we're going to go over that first. And then I'm going to bring up something very close to geriatricians. I'm a geriatrician, about age-friendly health systems and the movement that is relevant to bone health in particular. I'm also going to spend a fair amount of time talking about muscle and strength and function in the setting of osteoporosis and fracture, because I think it's ignored too often. And maybe I'll give some explanations as to why that might be the case. And then I'm just putting in quotations that very old is a risk factor for two things, I think. One is undertreatment, and the other one possibly is overtreatment. So let's get to this definition of very old. I think it depends on who you ask. So should it be a chronological definition? Like, I believe some, particularly in the younger generation, would think 65 is absolutely ancient. But if you're beyond that, you might think maybe 75 or 80, 85, 90, 100, greater than 100. How should we define very old? And at this point, I'd like to quote Bernard Baruch, who was a financier who advised both President Wilson and FDR. He defined old as 10 years older than what I am presently. So as a geriatrician, we think a lot about lifespan too. And my colleague, Louise Aronson, an author and geriatrician, I went to one of her talks and she took this picture from the internet that she said, if you type in images and look for lifespan, this would be pretty typical. And so what you might notice is that from age 0 to 100, there's a lot of detail given to those between the age of 0 and 20. And we have a language for that. We have newborns, infants, toddlers, children, preteens, teens, tweens, adolescent, young adults. And hopefully by the time you're in your mid 20s to 40s, you are gainfully employed, maybe you have a family. And then mysteriously, somewhere even around 60, there's this big empty space because I guess all you have to look forward to is to being in a wheelchair. And I put at the bottom of that slide, you see that usually in terms of healthcare providers, pediatricians are known to be experts in taking care of young people up to age 20, 20 plus. And there are about 70,000 pediatricians in the United States. And actually they're having trouble filling their residency programs now. And then internal medicine, primary care is about 120,000. I think family medicine is about the same. In geriatrics, when I started in the 90s, there were about 10,000 geriatricians practicing in the United States. When I came back to geriatrics in Stanford in 2021, I was absolutely shocked because there are just about 6,000 practicing. So if you're looking for a geriatrician to see, you might have trouble finding one. So I'm now living in Silicon Valley for the past few years, and I'm surrounded by tech and the longevity movement, if any of you have been affected. And it's a $40 billion annual industry, I think now. When you talk to people who are in this business, you come away feeling that perhaps they believe that aging is actually a disease. And when I went on Google and asked for what are the words, how do you define an older adult? I came up with this list and I only highlighted one, elder. To me, that sounded somewhat honorific. Um, and there's geriatric at the end. And I was thinking, wow, no wonder why very few people even want to see a geriatrician. And on the right-hand side of the slide is from the US Census Bureau. And I'd like to bring to the attention, I teach undergrads at Stanford. And I said, by 2035, the number of people in the United States who are over the age of 65 are going to outnumber the number of people between the ages of 0 and 18. So when you hear about the aging demographic, it's here, and I think most people know about it. That's important to bone health, allied health, and physicians and whoever takes care of older people with osteoporosis and fractures. As geriatricians, we actually know there was no definition in that cartoon of the lifespan about what actually happens over the age of 65. And what happens is we become even more heterogeneous than ever across the lifespan. And here are two examples of two 85-year-olds who look very, very different. And it's interesting that society, when I teach on the medical school and the undergrad, and I say, what percentage of people do you think actually reside long-term in a nursing home? And I get a variety of responses, but the answer is somewhere between 2 and 4%, if you were wondering. But I think most people think it's much more than that. So according to the Britannica Dictionary, referring to someone as an old person is very impolite. They actually have a language, and I thought the one between 60 and 69 was interesting because it's sexagenarian. But I actually saw it written, someone has used that term. 70 to 79 is septuagenarian, haven't heard that too much, but I have heard of octogenarian over the age of 80 to 89, nonagenarian over the age of 90 to 99, and a person who's over 100 is a centenarian, and I think most of us have heard that term before. So moving on to bone and thinking about having good health over a lifespan, we really need to maintain our balance and mobility to minimize the falls that often lead to fractures and usually are the main reason that people fracture. So moving on to this age-friendly health system movement, Mary Tonetti from Yale, along with the Institute of Health Systems Improvement, as well as the John A. Hartford Foundation, and I think the Catholic, and I forget the whole name, they got together and they said, there are never going to be enough geriatricians to take care of our aging population. So our job as geriatricians is really to make our health systems age-friendly. And they came up with the 4 M's. When it started in about 2017, maybe there are a few hundred who qualified by saying everybody who touches a patient should know about the 4 M's, which is 1, do you ask the patient what matters? Are you assessing their mobility? Are you assessing their mentation? And are you looking at their medications? Some geriatricians come up with 12 M's. So I just had the 5th M, which is to take care of older people often involves multidisciplinary teams. So focusing first on what matters. So here at the Santa Fe Bone Symposium, I think you're mostly here because you're thinking about how do we ensure good bone health for our patients? And how do we avoid the fracture? And how do we not fall down? The picture on the right is just kind of a public health announcement. Let's be active. Let's move. And the American Physical Association, Therapy Association says it should be about 150 minutes per week, at least, and muscle strengthening at least twice a week. So if we look at mobility and function and health over a lifespan, looking at this graph here, you see age on the x-axis and function and health on the y-axis. And if you're not very active, that's the red line. From childhood, you get more function because you can take care of yourself, hopefully independent. But as you age, there tends to be a decline of function and health. The blue line are those people who have been very physically active over a lifespan. And you can see that it's kind of like peak bone mass. If you get to peak bone mass and you start to lose bone after menopause, you have a longer way to go to get to that threshold of disability. The little green line there on the graph shows that, it's really never too late to start. So just say that you've been a couch potato your entire life. You can still get up and become active at any point. And I'd love to point out this article because it is actually so old. It was published back in 1990. It's a very small trial, but I loved it when I found it because it talks about high intensity interval training. And that's something over the past 5 years that we've seen a lot in the community for people who want to stay in shape. Well, here they did it in nonagenarians. They enrolled 10 older adults who were living in a single nursing facility. They were between the ages of 87 and 96 with a mean age of 90. And what they did was 8 weeks of supervised high intensity resistance training. And can go into the details of what that is later, but for interest of time, just say that after 8 weeks, their quadriceps muscle increased by 174%. Their mid-thigh muscle area increased by 9%. This is via CT imaging. They did of their lower legs. They also had increased function, which we geriatricians care about. Their gait speed got better, their stair climbing power got better, their balance got better, and they actually were spontaneously more active. And I could argue that nothing is as effective as reversing muscle loss as resistance training. So moving on to mobility, which is related. Why mobility? Because most people as they age like the idea of remaining independent. And once you become immobile, it's a lot harder to maintain your independence. So all of us in this room have thought about falls, and we know that fall prevention is important, but what do we do about it? I mean, the facts about falls in older persons, and this started, multiple epidemiologic studies have repeatedly shown that about 30% of community dwelling older adults, in this case defined as over the age of 65, report falling in each year, and that about 1 in 5 falls are injurious, leading to broken bones, and in particular, worrisome are head injuries and neck injuries. And that we also know from epidemiologic studies that a history of falls is actually a risk factor for future falls. And the slide on the right is a CDC slide showing that fall death rates have been increasing over time since 2007. And their updated data through 2022 even show that this rate is just increasing. And according to the website, they have, starting at age 65, that they have 26, 29, and 34%, depending between 65 to 74 or 75 to 84 or greater than the age of 85. I found it interesting because do we just start falling at age 65? Why does the CDC only have fall rates at 65? So some of my colleagues at Stanford and I conducted this national survey of 1,000 or so US adults representing multiple states who had to be age 18 or over to answer this survey. The median age turned out to be about 40 to 44 years, and 50% were female. And interestingly, about 34% in this survey reported having experienced a fall in the past year. And self-reported fall rates were similar, whether they were between 30 to 55, 55 to 65, and those over the age of 65. We just apparently don't care so much about those under the age of 65 and whether they fall or not. What is the evidence of what to do? There are multiple randomized controlled trials of exercise for fall prevention. They work. And in this US Preventative Services Task Force that we evaluated the evidence, felt that there were 5 good quality trials that all engaged gait, balance, and functional training that consisted of either group or home-based exercises, about 3 sessions a week for about an hour, followed for about a year. And they concluded in their JAMA report that exercise works to prevent falls. These are veterans getting up from a chair without using their arms and working to improve their balance and strength. In terms of other fall prevention strategies, there have been multifactorial interventions that have been done as well, including 7 good quality trials that involved comprehensive geriatric assessment or fall risk factor assessment. For instance, measuring the balance and gait, making sure that people are wearing the had corrected vision as much as possible, checking for postural hypotension and orthostatic hypertension, looking at their heart rate, reviewing the medications, looking at the environment, removing home hazards such as loose rugs, and then assessing their cognition and their psychological health. The U.S. Preventative Services Task Force then concluded that overall, both multifactorial and exercise interventions work to decrease fall rates, but actually exercise does a little bit better. So in my clinic, when someone comes to be evaluated, whether it's for bone or something else, I really observe how they're moving. So they might already be sitting in a chair or they're not. I watch them sit in the chair. But if they're sitting in the chair after talking to them about what matters, I ask them to see if they can stand up from the chair. And they look at me strangely, but then they abide. And if they look like they're unsteady, then I say, please, I try to ask them to do it without their arms, but if they can't do it, they might swing back and forth. And then I can see it could be a dangerous situation. I could have a hip fracture right there. I ask them to sit back down and use their arms or use whatever assistive device they have. And then I ask them see if they're steady on their feet and they feel okay to do a semi-tandem stand, which is the picture on the right-hand side of the lower 3 pictures. And that's basically having their feet closely opposed together, but not quite one in front of the other. And if they look pretty steady with that, then I ask them to do a tandem stand, which is 1 foot in front of the other. And then they ask me if I'm testing them for alcohol intoxication or something. But some then proceed to do the tandem walk. And I say, that's great. But if they do that without any problems, then I say, can you stand on 1 leg? And I keep on pushing it until they get something that is challenging to them. So if they're really standing on 1 leg for 30 seconds, then I tell them, then can you please close your eyes? Usually someone can find something to improve and work on. And then I tend to recommend exercise, but I want to be very careful about how I use that word because my husband's father used to say that whenever he would get the urge to exercise, he would lie down until it went away. So instead of saying that, I say, well, I think you're here for bone health or you want to age well. Let's just conceptualize yourself as being comfortable and aware of your body and space. So we talk about goals. Now, some people don't care. So if they don't care, I stop because it's not worth the time. But if they care, then we say, well, how can we work on these goals and maintaining good health? And then I provide them options. It's not that there's a one size fits all on how to become active, but certainly there are multiple Tai Chi trials that have demonstrated a decreased risk of falls. And then when I moved up to Palo Alto and was seeing patients at Stanford, I had a fair number of Asian women who were older who came to see me with T-scores in the negative 3.5 or lower range, never fractured in their life, in their 80s. And then I do this stuff and they're basically getting down on the floor doing squats and getting up. And I thought, wow, no wonder why you never fracture. You can actually get down to the floor and get up without using your arm, forget the chair stand. The multimodal exercise and working on balance, being aware, however they want to do it, I don't care. They got to find something that works for them. So if it's dancing class, if it's a jumping rope, I don't care. So I'm going to move on to mobility and with muscle, because muscle, I think, is not talked about enough at bone meetings for some reason. And I'd like to ask this question. Could muscle play a more important role than bone in determining mobility, falls, and fractures as our skeleton ages? And one could argue, when I thought about this, that low muscle strength is definitely correlated with low bone density. There's clearly a lot going on at the molecular cellular level between muscle and bone interactions, whether they're hormonal, cytokines, signaling growth factors, whatever. There's something going on biologically there. Low bone density, we know, even with DEXA, which is an imperfect test, will help. If it's low, people are going to be at high risk for fracture. And here I just put hip fracture because that's kind of the devastating fracture that people most worry about. Low muscle strength, however, is also a risk factor for mobility limitations. And those mobility limitations lead to the fall. And it's generally the fall that leads to the hip fracture. I have the other arrow from the hip fracture going to the fall, for instance, except in the case of atypical femoral fractures, but also orthopedic surgeons have seen people who say, without even bisphosphonates, that I had pain and I heard it crack and then I fell down. So it can happen. So as a geriatrician who've seen and treated people with fractures, I would argue that muscle is a crucial factor in determining regain of function following a fracture. And those outcomes after a fracture depend on their premorbid muscle strength and function. So if they were sarcopenic, the likelihood of regaining independence is more questionable. And I don't want to not pay attention to bone. Clearly, the bone density, geometry, the degree of mineralization, the microarchitecture, and bone turnover are all super important for healing. However, without having the sufficient muscle function, even with healed bone, some patients will never be able to regain their previous function without adequate muscle. So if that's the case, and looking at that diagram, could muscle actually be the most important factor in contributing to fracture risk in older people? Most fractures occur from a fall, and in observational studies, namely the study of osteoporotic fractures and the osteoporotic fractures in men study, they estimated about 83 to 87%. And of fall risk factors, though, if you want to prevent the fall, muscle weakness and not low bone density is listed. And if you try to get to the statistics, what are the proportion of fractures that are attributable to osteoporosis defined as a t-score of negative 2.5 or lower is modest, only ranging from even less than 10% to 44%. And it is true that more epidemiologic studies highlight low bone density rather than muscle weakness as the important fracture risk factor. Whereas fewer studies show an association between muscle strength and or performance and fracture risk. And there are a few studies, and even more maybe two today, that have compared low bone density versus sarcopenia and looked at fracture risk. So there's more interest, but you might ask, why has there been a focus more on bone than muscle when both are clearly important for musculoskeletal health? Well, sarcopenia, or low muscle mass and strength, are just simply harder to characterize. So if you get a cross-section CT of the thigh, it's pretty easy to see, or even clinically, I can argue, when you watch someone move in a clinic, you can get a sense of, okay, who might not be sarcopenic versus sarcopenic. In fact, in 2016, sarcopenia now has an ICD-10 code associated with it, and it's defined as low muscle mass and low muscle strength or performance. And it is thought to be the most common cause of frailty in older persons. The clinical definition by a working group is based on walking speed of less than 0.8 meters per second, as well as low grip strength defined as less than 20 kilograms in women or 35.5 kilograms in men. The measures of muscle mass have been difficult over the past 25, 30 years, and only recently I'm going to point out the D3 creatine measure of muscle mass, which has been much better than the DEXA-based measures of lean mass and being able to predict things that matter to older persons, such as declining gait speed, developing mobility limitations, being associated with an increased likelihood of having serious injurious falls, and fractures. So if we look at the kind of trajectory with muscle affecting mobility, that could then lead to falls, which then would lead to the fractures, we're thinking about frailty. And Linda Fried came up with a criteria for defining what is frailty. And there are 5 major criteria she looks at: weakness, slow gait speed, physical inactivity, fatigue and exhaustion, and unintentional weight loss. And if anybody has greater than 3 out of these 5 criteria, they're determined to be frail. Roseanne Leipzig just came out with a nice book called Honest Aging, and this is a snapshot of her picture where we think about sarcopenia and the cycle of frailty, where there is this age-related decrease in muscle mass leading to sarcopenia that could be caused by inactivity, acute illness, undernutrition, obesity. You may have heard the term sarcopenic obesity, chronic diseases, medications, and there I've highlighted decreased muscle strength, exercise tolerance, increased exhaustion, decreased motor performance leading to slow walking that then makes you not want to walk anymore. So then you have decreased physical activity that then feeds back into the sarcopenic picture. So let's think about muscle strength over a lifetime. So muscle strength and loss over a decade tends to go down, we'll say, just say in the 50s, okay, according to this graph by gender. Men, losing somewhere between 4% to 8% between the 60s and over the 80s, to women having even more substantial muscle loss, 9% to 12% as they get older. What about if you become immobilized? What happens to your muscle? So in terms of atrophy per day, if you're healthy and you are in bed for 7 days, you could have a 5% of your muscle be lost. And just imagine if you're in the hospital, and usually it's for something acute, so your inflammatory system is all over the place, 13% in a week. And if you go to 2 weeks, then it can be 6.5%. And if you're in the hospital, it's really bad. It's like 28%, according to this study. So it turns out in 2024, there's not an easily quantifiable measure of sarcopenia to assess fracture risk, but we definitely know it's a risk factor. So walking speed, though, is something that's more easily assessed. And from one of the physical therapists that I've worked with at Stanford, Michael John Farva, he had this nice slide which shows that walking speed, and we know from the Mr. Oz study that 1.2 meters per second for those guys who are now getting into their 90s is a good walking speed. And you can see correspondingly, you're going to be independent in your activities of daily living. You're going to be less likely to be hospitalized. You're less likely to have an adverse event. If you were hospitalized, you're more likely to go home directly. You can cross the street well without being worried that the cars are going to run you over. But literally the 2.7 miles per hour, is the same as 1.2. But as you go lower, you can see if you're less than 1.3 miles per hour or 0.6 meters per second, that's when you're more likely to suffer from an adverse health event and less likely to remain independent if you were had to be hospitalized. So mentation. We don't talk about this much in osteoporosis, but it's definitely a risk factor. So I was lucky enough to hear this graduate student in epidemiology present this data, and she sent it to me over the plane about her results from the 90+ study, which is out of Irvine, California. And she asked the question whether the combination of cognition and slow gait speed would be more strongly associated with future falls than just being a slow walker. In her sample, there were 1,039 who with a mean age of 93.5 years. They measured gait speed, cognitive function, and incidence falls over 3 years of follow-up. At baseline, 50% of the sample had impaired cognition, defined as mild cognitive impairment or dementia, and about 43 to 44% reported falling in the past year, similar to the CDC estimates of those over the age of 85. So here are the interesting study results. So on the left are the women. There were 710 of them who stayed in for 3 years. And green is one. They didn't have slow gait speed or impaired cognition, but the women, if they had a slow gait, were statistically significantly more likely to report a fall over the following 3 years. But impaired cognition, slightly more, but not that much more, and not statistically significant because the 95% confidence interval crosses 1. But if they had both, they were definitely 1.5 more likely to have a fall. The men were the interesting guys because there were 329 in the study. If they had a slow gait, then certainly they were more likely to fall, 1.69. If they had impaired cognition, 2. But if they had both, they were at the highest risk of reporting a fall over the next 3 years. But when I was doing osteoporosis care at UCSD and then at Stanford, I would see people and they'd come to clinic and maybe they had a fracture and they'd just go, "Doctor, I'm just a klutz. I've been a klutz my whole life." I'm like, "Okay, that's nice to know, but why do you need to be the klutz for the rest of your life?" So I really encourage people to be in the moment. If you know you're at risk for falls, think about how you can change that risk. So absent-mindedness is associated with fall risk. And we use our cell phones when we walk. People will trip and fall. Not thinking about the future or yesterday is not a good thing either. It could be a risk factor for falls or anything that affects mentation, right? Alcohol use, substance use, medications, and having a fear of falling actually can increase your risk of falling as well. That's been shown. So lastly, medications. So I'm very old and I still haven't really defined it yet, have I? Uh, I will say, if you ask a geriatrician in senior Stanford healthcare to see a geriatrician, you have to be over the age of 80. Or if you're younger than the age of 80, you have to have some chronic health conditions that our geriatricians are specially equipped to take care of. But I think a lot of the geriatricians was maybe use very old. Okay, maybe 85 would be their definition, I think. I didn't take a formal poll, so I'm not sure, but that's my gestalt. But the problem with thinking about old is that it's a risk factor for undertreatment because people start getting written off, right? Preventive care kind of stops. You don't really need these things because whatever it is, some screening exam, because you're not going to live much longer anyway. And randomized controlled trial often don't include the very old. And I think ageism is a part of that. But they're also overtreatment risk factors. We may be missing what matters to the individual patient, right? So we really need to listen what is important to them at that stage in life. So for us, we're all invested in bone and we think we know that there are medications and their data that they should be on a treatment. But really, if that's not what is important to them, then maybe that shouldn't be felt so strongly by you. You should listen to your patients. And a lot of us, because we're so busy, we miss that medication reconciliation at each medical visit. And just like if you have not moved in a long time, you just accumulate stuff. So the same thing tends to be true of medications. We just start accumulating pills that we're taking, and oftentimes there are a lot of supplements that people don't even consider pills. And so you're getting at numbers of 20, 30. I've had people bring ice coolers with their medications because I say, "Can you please bring your medications to clinic?" And literally I took a picture once because it was an ice cooler full of the number of pills. And we know that medications are linked to falls and falls lead to fractures. So please review all the medications in all your patients, really, but particularly in those over the age of 65, because these medications, some are associated with increased risk of falls and even fractures. So it's best, there's a whole deprescribing movement that's going on in my field to really do medicine reconciliation and start removing medications that are not really having a clear indication. So now I'm getting to the meds. These are slides courtesy of Dennis Black, where the stratification, I guess, for very old in this case is 75. But I think the reason why was more based on the numbers that you could actually begin to show an effect in a stratified age group, because there were just fewer women who were enrolled in these trials over that age. But the bottom line for hip fracture risk reduction is the confidence intervals definitely cross one because the sample wasn't large enough, but you can see the point estimates are all favoring treatment. So whether they're under 75 or older 75, alendronate, zoledronate, denosumab, and teriparatide all suggest that, yes, if there's an indication, whether you're 75 and above or 75 and below, it doesn't matter. You should consider treatment. Vertebral fracture risk reduction, it was easier to show to be statistically significant in the older adults, and that they all were statistically significant with alendronate, zoledronate, denosumab, and teriparatide. So, and if you look at publications, because you want to, basically they all are agreeing pretty much that treatment does seem to be effective in the older population. So I went to Dennis earlier this spring and I said, Mike asked me to come speak and I really want to see what's going on with abaloparatide and romosozumab. So thanks to him and his group, we were able to get those data from the SABRE ongoing studies where Lily Lay created this figure where all placebo-controlled trials clearly show whether you're over or under the age of 75, there's a definite benefit. And in ARCH, which was the romosozumab trial, clearly a benefit. The other romosozumab trial, clearly a benefit. And in the active extent for abaloparatide, definitely a benefit, regardless of which age group you're in. And I thought it was interesting when they sent me this slide that if you were in the older age group, your benefit seemed even better, which then an audience member asked a couple of days, or just yesterday, time flies, what is the number needed to treat? And thank you for putting together that great quick presentation in short notice. But we did this for this particular data. And what we see is that numbers needed to treat actually go down with age, given that fracture risk is higher in the older age groups. So for example, with these data, the number needed to treat for hip fracture is 200 if you're less than 75. And only 50 if you're over the age of 75. And for any clinical fracture, the number needed to treat is 26 under the age of 75 and only 15 in those over the age of 75. But what about considerations for an older patient with osteoporosis? Okay, I would argue that osteoporosis drug treatment works, even in the oldest old. Of course, treatments, any drug that you take, are associated with immediate burdens and harms, such as GI upset in this case with the bisphosphonates orally taken, infusion reactions for the IV forms, dizziness if you take the anabolic injectables. Actually, I've had pretty good experience with romosozumab so far, but there are risks. Thus, in an older patient, it may make sense to think about the time to benefit, right? I think I heard via a train of discussion that some people are asking, well, if you're really old, what's the use? Why would you even prescribe these medications? So geriatricians are aware of that. So we are thinking, okay, well, we're not good. Any physician is really not good at predicting mortality in any given individual, but we can use data to get a sense of what the time to benefit might be to help treaters. So luckily, thanks to James Deardorff, a geriatrician at UCSF, and Say Lee, his mentor, they took the randomized controlled trials of bisphosphonate therapy and were able to publish, I think it was in JAMA, that you only need to take treatment for 12.54 months to, or have a life expectancy of greater than a year and 4 months to have a benefit from the treatment. And just in the, and that's over 3 years, I think, based on your point of what's the time to benefit over what time. For statins, in this particular trial, it was 2.5 years. And in addition, we've even had discussions and debates at ASBMR about whether bisphosphonates could affect the risk of mortality, since so many of the randomized controlled trials demonstrated that people who were randomized to the bisphosphonate actually had a longer survival than, statistically significantly, than the ones who took the placebo. So some final thoughts, and I think, am I keeping up 40 minutes? Oh yeah. Okay, about women versus men, as many believe that osteoporosis is a women's disease. I would say that men really should be informed of their risk, and we really need to fight for deficit payment by the insurance companies to do screening in men. Because in fact, and from this meta-analysis recently published in March of 2024, the increase in fracture risk after a fall in the previous year is greater in men than in women, with a hazard ratio of 1.32 in women versus 1.49 in men. And that for women, if they've had a fall, their risk of fracture actually goes down with time, where it doesn't so much for men. And then I showed that early data for the older men who had both cognitive impairment and slow gait speed. They were the ones who had the compounded increased risk of falls and probably fractures. So just something to keep in mind. Finally, lifestyle and diet influence not only mobility and falls, but overall biological aging. So both of these women, a picture I got from the internet, are age 74, again, showing huge heterogeneity in aging. If you don't know and recognize this woman on her arms doing the peacock and a half lotus position, that's Tao Porchon Lynch. She holds the current Guinness Book World of Records of being the oldest woman yoga teacher. She actually had a wrist fracture in her mid 80s. And her orthopedic surgeon said, "You're never going to be doing that again." And I can just say, I can still not do that or ever will be able to. And she had hip replacements, and there she is. This is Don Perlman. He's a Santa Clara County resident, participating in a San Diego triathlon. He was 99. He made it to 105. I think Tao made it to 102. And this is Geraldine Shepard. But here she is. I think she just turned 88. So there she is. Of course, these people really keep physically fit. In honor of the Olympics, that's Joanna Cross. Cross, I think she's in her late 90s now. She competed in the Olympics at age 9 from Hungary. So it's not like I interviewed these people, but I wanted to know what they ate. And they all had healthy diets as far as I could tell. Lean meat, fish, salad, soup, and as much fruit as possible. And Ernestine Shepard, sorry, I got her name wrong. Ernestine Shepard likes to have eggs every day and chicken and vegetables. So clearly what you put in your mouth, your body has to process. So some people are in the food is medicine movement. There is something to that, I think. But being a master athlete is not a prerequisite for doing well into our 8th decade and beyond. But I would argue it takes work. And this is not related to bone, but this is this idea. If you are a sedentary couch potato, even getting little bouts of exercise or movement or something, like 3 to 5 minutes, 1 to 3 minutes, you see a big improvement in terms of mortality risk decline, as well as a decreased risk of a major cardiovascular event. And just a little bit more about Ernestine Shepard. She didn't start exercising like that until her late 50s because her sister died of a stroke. And she was very, very depressed into her early 60s. And it was one daughter who really encouraged her to get up and do something. And so she really has a whole nother career now. So with that, I will leave some time for questions. Thank you for your attention.
Yeah, hi.
I'll start with one from online. There's a couple of them, they're similar themed. The effect of weight-bearing exercise on BMD. And is that sustained, or if you quit doing the exercise, does it diminish?
Okay, so some trials out of Australia, the Liftmore trials definitely demonstrated a benefit of weight-bearing exercises on BMD. And I think the second answer is, yeah, unfortunately, it's like when you go to a physical therapist and they give you some exercises to do and you show up for an hour, 3 times a week and get some benefit. If you put those sheets on the side of your bed table and they just sit there, they are not going to help you and you're not going to get better. So this is a lifestyle change recommendation. You can't just assume. So even those people who did the high intensity weight training at the nursing home back in the 1980s, if they didn't continue, they had a decline. Their 174% increase went back down to baseline.
Hi, Ray Adelisi, rheumatologist, Cherry Hill, New Jersey. So do you treat at any age? I know sometimes I'm in a quandary. Somebody's 92. Should I treat them, especially if I'm getting pushback from the family saying she's too old, isn't she?
So in my patients who are over 90, it's interesting to hear where they're coming from, right? So a lot of times I begin that with not only what matters, but what are your goals? And literally some patients have laughed at me in my face saying, I haven't thought about goals in a long time. So I go straight to the patient if they are not totally cognitively impaired. And I kind of ask them like, you know, you're not going to live forever. So what is most important to you? And if they say, my so-and-so died of a hip fracture and it was just the most devastating thing, I would say, absolutely. We have things that can help you that weren't available when your parent was alive. So yes, but it's really the context specificity of individualized treatment at that point. But I would not use age as a cutoff. I would use function.
Gina Woods, UC San Diego. Thanks so much, Deb, for a fantastic talk. I still do the chair stand and the tandem stance in patients, just like you taught me, and I love your holistic approach to care. My question is about response to treatment based on age in terms of change in bone density. So if we're going to be using change in hip BMD as a surrogate, does that differ by decade of age?
Great question, Gina. So great to see you. I don't know if we have those data, so I can only share my anecdotal experience. And sometimes I have patients come to me. I'm just thinking of one in particular who came to me at UCSD when she was 77 and her T-score wasn't good, probably negative 2.8 or lower, and hadn't fractured, but the primary was really upset. Like, why is she not on treatment? And I spent an hour describing benefits and risks and saying, this is really important. And she said, thank you very much, doctor. And then she left. She came back at age 83. I gave her all the exercise things that I do. And she had a reason to live because she was taking care of her developmentally disabled adult child. And she was the caregiver. She came back to me with a repeat bone density 5 years later, and she improved significantly, like less than 2.5. But she came back because the primary said, you know, you were seeing Kado, you better go back and see her for this repeat DEXA. And it was pretty well done. And so I think that again, it's individualized on the whole. I understand the SABRE project and why we're treating to that endpoint, but at the same time, I can't say that I would expect less. And from other studies in the very old, we can see amazing benefits like we did in those who were in their 90s. So I don't think we should use age as an expected, like they're not going to improve as much. I think they might actually improve more.
Great, thank you.
That was a gorgeous talk. Terrific. You had a slide from Maria Fiataroni, and that reminded me that at your current institution and my former one, we actually had a symposium, a day-long symposium on sarcopenia back in the late 90s sometime, and Maria spoke. At the same time, there was a neurologist who spoke and said, you people who are interested in bones know about remodeling, a continuous process that lasts throughout life and is not 100% efficient, and that's why we lose bone. The same thing occurs for motor end plates in somatic muscle. And so ever since I heard that, I've followed tables of contents to see if anybody has picked up on that idea and whether there's been any further information about that, because that would be a therapeutic target if it were really true. And I'm just wondering if you have any more knowledge, because you're not retired and you might.
Yeah, so we have the WUSA Human Performance Alliance at Stanford, where people are actively looking at those neurologic and muscle interactions, both on the molecular as well as human performance level. And so I don't think we have answers or therapeutic targets yet, but I think those are the investigators' hope at this point. And also very specific to neuromuscular degeneration is something that they're really looking at, like why this happens, particularly in people who are affected by movement disorders. So hopefully we'll have something to report.
There's a theme online asking about handouts that you might recommend to give to patients, elderly patients for exercise, maybe some website that you could share.
Yes, so I'm going to think of, and it's not that I personally reviewed these, but I think Laura Giangorgario from Canada, who's a kinesiologist, has a lot of great resources. I think, is she at the University of Waterloo? Is that right?
Yeah, we've had her, I think,
Yeah.
here or someplace.
Yeah, I think she has some good, and then there's somebody else who is really passionate about this, who I've met through the Bone Health Osteoporosis Foundation. I think she has a site called Buff Bones. Maybe, I know there's some representatives. I saw Amy Patel here earlier, but there may be some good resources through the Osteoporosis Foundation there too.
Susan, sorry, left. Bring the microphone down because you're short.
There's nothing wrong with being.
No, I didn't say that.
Nothing wrong with short.
So
It has some advantages.
exactly right. Small, I think what this is, good things come in small packages. So I'm Mansi Mehta, endocrinologist in Albuquerque, New Mexico. So any secret to getting DEXA scans approved for men age more than 70? It's very hard to get this approved by Medicare.
Yeah. I wish I had a good answer for that. I mean, if you can think of any medical indication, I don't have the answer to that in a really, I try to take the individual and find some reason that would qualify it, but I don't have a pat answer.
Right. So do you do things like maybe decrease in height or something like that, sneak it in and just kind of, I don't know, because it's otherwise Medicare just denies it.
Yes. Yes. Sorry.
Susan?
So, in the last couple of years, there's been a lot of pressure to discharge people who are healthier and more functional to home, even after a fragility fracture. And in fact, we get graded on that in orthopedics. Now we're seeing patients who are better, more mobile. They get a fragility fracture, they go home or they go to their families. It might take us 2 weeks to get PT to them. And their families just can barely manage them with like sit to stand. How do we help those people? How do we advocate for, either getting them to rehab? Because they're the ones actually who have the most muscle to lose. And DEXA has shown us the healthier, the people who come in with more muscle actually lose more muscle after hip fracture or upper extremity fracture.
This is where finances help. So I think in general, it's great to stay out of the hospital. So I'm not upset about the early discharge necessarily, but that follow-up is so important. And if you can't get someone there to really help the family, that is a problem. So oftentimes, especially for my very old patients, if they have resources, that's when they spend out of pocket to get the kind of care that they need to be able to get the best maximum benefit of physical therapy within the home. But if they don't have resources, then
Yeah.
you might say actually to have daily access to someone who's getting you out of bed, because even if it's not a fracture related outcome, now surgeons know we got to mobilize these people as soon as possible. So there's a whole movement for that.
Thank you.
Microphone on the left.
Alex Hertzman from Baltimore. I'm a rheumatologist. So I've been treating osteoporosis actively since '96, and a lot of my patients are getting older and some into their 90s. And the question is, which patient would you not treat? I mean, a 90-year-old who's in a wheelchair is becoming frail, starting with dementia, coming in with their family. Do you have a definition of someone who just, it's over treatment?
Yeah. Okay, okay. This is a good question. This is where it becomes very individualized and I deal with it when I used to do inpatient medicine too. If someone has a laundry list of 10 medical problems and you notice they have a really low BMD, I'm thinking about osteoporosis, but that's not the thing that's going to kill them first. So I really start beginning to think about competing risks of what's going on. And so someone who you just described, who's not going to understand why they'd be taking an extra medicine, is going to be giving the caregivers extra stress. Oh, what's this? Am I supposed to take it, on an empty stomach, sitting up for half? I mean, just those kinds of things really can impact the quality of life. So I might be less likely to treat in that particular situation.
What about the patient who's already been on treatment
Oh.
and decision to stop in that
Okay,
that situation?
well, if it's denosumab, as long as I'm making sure they're coming every 6 months, I will say just continue the denosumab. And they've got a routine, it's going on. If it's a bisphosphonate, because of the long life of that, I might say one less thing to have to take I will just say, that's in your system, you've done a good job, and I might say, let's simplify the medication list. And often in that age group too, you're dealing with chronic kidney disease, and that's something that really sometimes becomes a limiting factor. Actually, when the EGFR gets close to 30, then yeah.
Okay, one final question, Dr. Lane.
Jerry, we did a study looking at function versus DEXA. It doesn't really correlate very well. They're different domains, yet both lead to fractures. So the question for you is, do you have any data as to how often a bone doctor actually does a functional exam when they see the patient per year?
Oh, Gina Woods? No, I don't have any data on that. No.
See, I think this is very critical. I think this is very important that this be added to and included in.
Okay, well, this is
exam.
an informed audience. Should we have people who are not physical therapists and allied health raise their hand if they do a bona fide gait assessment when they do osteoporosis assessments? So this is an informed audience, and we didn't have 100%. So we probably have a ways to go. Thank you for that question.
Okay, thanks, Dr. Kado.